Hey, it's Dr. Centeno, and thanks so much for joining us today. This will be my last AMA Ask Me Anything Facebook Live before I head out on sabbatical. And a couple updates to share. One is, what the heck is a sabbatical, right? Does this guy take a vacation and he calls it a sabbatical? What is that? Basically, sabbatical because I do this 3 months out of the year, and sabbatical because I still work, but don't work as much for that 3 months out of the year. So, my average work week right now, all in, is probably 80 hours a week, 70 hours a week, something like that. So when I'm on sabbatical, it might be 10, 20 hours a week. So some difference there between what I normally do and what I do when I'm on sabbatical. So that's why I call it sabbatical. The other reason I do that is because my dad developed what's called diffuse Lewy body. And diffuse Lewy body is kind of like all the bad parts of Parkinson's with the bad parts of Alzheimer's, dementia, with some hallucinations thrown in towards the end for good measure. So really bad thing to have. In fact, it took a while to get him diagnosed because, most of his neurologists thought he had Parkinson's. And the reason I do this is because he and my mom had great plans about all the things they were going to do. They raised 7 kids. They put those kids through college. And ultimately, they didn't get to do them simply because he got sick, and my mom took care of him for a good decade before he passed. So that's why I do this. There's no indication that I've got that, but you never know. And my overall sense is might as well get out there and do some of those things I've always wanted to do before it's too late. So a couple housekeeping things. One is on the PICL pro bono program for CCI patients in need. I just updated the Reddit sub on that, and we had 8 applicants. I suspect there may be more, but I'm pretty sure some of those didn't follow the rules that I had laid out. We had one of those applicants who actually got everything in for the pro bono PICL. So that applicant will take the September slot for basically a free PICL procedure. So the applicant was notified, and then I posted the rules just so that everyone can get a sense of how this works. We're still waiting to hear back from 7 of those 8 patients. And I think there's probably at least 5 or 6 more out there, but I don't think they followed the rules as well as those 8. So the rules are up on the PICL subreddit. So my job here today is to answer your questions. So if you have any questions, put those in the comments below. Literally just put your question in the comments. I'll get those here, whether you're on Facebook or on YouTube, and then happy to answer any questions you have. Again, just to update, this will be my last Facebook Live before I go on sabbatical. I'll be gone about 5-6 weeks. I will have daily content scheduled to come out. I'll still check the PICL subreddit numerous times a day while I'm gone. And so I'll still be actually doing telemedicine follow-ups and other things while I'm gone. So again, if you've got any questions, just put those in the comments, and happy to answer those questions. Also an update, we did pick the September winner, if you will, of the pro bono PICL slot. So that patient will get a PICL procedure done free of charge, assuming they're an excellent candidate for the procedure. The candidacy of that patient still needs to be determined. Obviously, if it turns out that that patient's not a great candidate, then we'll move on to the next person and go from there. So it looks like we've got some questions coming in. Thoughts on MLS therapy? Yeah, so MLS is a type of laser. The biggest issue is it all depends on what it is we're trying to treat. If what someone has is just some irritated suboccipital tendons and or occipital nerves, an MLS laser may help. Even if someone just has some ligament laxity, let's say at C2-3. Now, we don't have any research showing that MLS laser can treat that, but at least that's reachable with an MLS laser. So from my perspective, that's worth a shot. That's a type 3A CCI. Having said that, if you look at the internal ligaments that we're trying to treat, and that would be alar, transverse, accessory, etc., an MLS laser is just not going to get there. Laser is light. It's not magic. And if you shine a light in through those bones, you don't get much of that light into those internal ligaments. So for the other types of CCI, that's going to be 1A, 1C, 2A, 2B, 3B. You're just not going to get anywhere close to the structures that you need to treat. So anyway, that's my thought on MLS laser. I don't think it's going to be able to treat most types of CCI. And if you have a lot of resources, you may just want to go for it. If you don't have a lot of resources, I wouldn't waste my money on MLS laser. I'd save it for something that's more likely to help. Let's go on to the next question here. If your sabbatical is in Europe, any chance you can spread the CCI gospel in Europe, since they seem to be behind the curve in CCI care? Yeah, Casey, and that is so true. The good news is you guys do have Dr. Gillette's clinic and Dr. Oliver. Obviously, they seem to be up to date on CCI and from the standpoint of being able to diagnose it. The bad news is I would agree. It's probably harder to get a diagnosis for European patients than it is for our U.S. patients. And it's hard enough for our U.S. patients. And that's probably because Europe has fewer private care channels available than the U.S. The U.S. has tons and tons. Europe has very few. So I would agree with you. I don't know if I'll be spreading the gospel so much about CCI as much as spending a lot of time on a boat, but I will be, I've got a Starlink, so I will be continuing to spread the gospel online, so to speak. Tom, I was diagnosed with CCI and neck pain. Isn't really an issue for me. It's more to do with autonomic issues, dizziness, anxiety, excessive sweating, etc. Is PICL still effective? Well, Tom, I would first need to know what type of CCI you have. So the first step would be movement-based imaging. That's going to be a DMX or an upright MRI with flexion-extension, or even flexion-extension x-rays. As I describe on my YouTube channel, you can get a DMX type open mouth lateral bending done just at a local hospital that does good quality flexion-extension x-rays. Then we've got to type it and see what kind of CCI you have and if you have CCI. And then the question becomes, is it possible to have CCI and just autonomic symptoms and not neck pain? It is possible. We do see those patients. And we've only started to accept them over the last 2 or 3 years because previously we didn't really know how to qualify them for this procedure. But they seem to do quite well as long as we confirm that the CCI is likely to cause the symptoms. So final answer is yes, it's possible, but there's a lot more information that has to be put together. Casey, and shockwave therapy have any regenerative soft tissue future? Yeah, so shockwave is a lot like laser, right? It's not a therapy that's going to penetrate very deep. So for superficial structures, it basically causes a small microinjury, kind of like a very weak prolo session. So you can get some healing that happens. Now, is it going to replace even prolotherapy? It's not, because you can be much more exact as to where you want to go under ultrasound guidance with prolotherapy. And it's certainly not in the same league as a PRP injection or a bone marrow injection. But for superficial structures that can be reached, which would be things like the tendons at the back of the head, the superficial supraspinous ligaments in here, then shockwave might be something to consider. Now, if you were trying to decide how to use your resources, which is what I said to the laser person that asked about that, then I think you may want to not spend a lot of money on shockwave or laser and save your money for things that are more likely to work, which would be injections. And again, if you've got an internal ligament type of CCI, shockwave is very unlikely to work. Krista, in regards to the pro bono program, if someone meets the income requirements, I don't understand why it matters that they're a past patient. Some lose their jobs at a CCI. Can you explain that reasoning? Yeah, Krista, the focus on that program is to try to do the maximum amount of good. And that maximum amount of good is going to be allowing someone who has zero access to a procedure, access to a procedure. So that's the reasoning on why we're doing it that way. I don't anticipate that changing anytime soon. That was a decision that I made after much contemplation because we've got people, for instance, in third world countries, for example, that earn, even on public assistance, about a third as much as a U.S. patient on public assistance. So that's my thinking there. Opale. In case of a whiplash followed by aggressive overtreatment, would a standard supine MRI be sensitive enough to identify soft tissue damage versus nerve irritation, especially around the stihyoid areas? I cannot afford the upright MRI, and DMX has already confirmed CCI. There are certainly clues that you can get from a standard MRI, meaning a supine lie face up in a tube MRI. So yes, having said that, you're not going to get as much information as out of a flexion-extension upright MRI. So what are the kind of things that you can see on a standard MRI that might be soft tissue based? Well, you can see muscle size, you can see muscle atrophy. You're not going to get a lot of information about the nerves, however. That's going to be more an MR neurogram. That's a very specific kind of MRI that enhances nerves. You can get a little bit of information about the blood vessels, not that much. They tend to show up as voids. You can certainly get information about joints that are swollen, for example. So we do see swelling, for example, in the upper facet joints on a routine MRI. And you can get information about increases in signal in some of the ligaments. But remember, a routine MRI is not going to show these hypercervical ligaments because they're programmed to show everything from C2 down on the axial cuts. Now, in some of the sagittal cuts, we will see some of the deeper ligaments. But for example, we won't be able to see the coronal and axial cuts we need that would allow us to determine the status of things like alar and accessory ligament. So you can see some things and not others, but at the end of the day, just realize that the standard supine lie face up in a tube MRI is not going to show the hypercervical spine because it's just not programmed to do that. Sid, what might explain why carrying medical claims have a 60% or 60 to 70% success rate with Prolo versus Regenexx 20% success rate with PRP? Is that you see more severe cases? I'm not quite sure what you mean, Sid. None of that makes much sense. So basically, I think what you're trying to compare is a type 2B instability at Curing Medical, where they're claiming 60 to 70% success rate. I don't see that. A lot of our patients are Caring Medical patients that have failed Caring Medical care. So I don't know what to say as to whether or not their success rate is viable or not. Now, I do know that Caring Medical tends to treat much, 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 much more than we do, meaning that for us, if we're seeing someone 3 or 4 or 5 times, that's a lot. And Caring Medical is often in that 8, 10, 12 or more times range. Having said that, even with much more advanced posterior injections, with PRP, I think what you're bringing up is type 2B. That doesn't work well, just doesn't. And I'm the first one to say it. It's one of the reasons why we developed a PICL procedure, because posterior injections, whether those were prolotherapy or PRP or much more advanced than Caring can offer, getting into the joints, for instance, with X-ray guidance and contrast confirmation, getting into things like AO ligaments, just didn't work for that patient population. So not quite sure where Caring's getting those numbers, because we don't observe that at all. And we do far more sophisticated injection procedures than Caring that would be expected to work much better. So not quite sure what else to say there. Caleb, week 4 out from my PICL, normal to have some setbacks, definitely noticing worsening air hunger, but I also have dysautonomia, so I'm sure that has a lot to do with it. What month do you recommend getting the second PICL? Yeah, Caleb, just look at all that information we gave you. That should describe everything you need to know. So sounds like you're in the donut hole. The donut hole is, for some patients, the initial swelling. They actually feel great for that first week or two. Then the initial swelling goes away. And then at around month 2, 3, or 4, we tend to see tissue remodeling and things start feeling very good again. We call that time in between there the donut hole. So it sounds like you're in that donut hole. But all that information is in the information you received. There's about a 14-page document. So it's all in there. Kasian, any thoughts about starting a journal to get better access to medical providers who need up their regen game? I'm not quite sure what you mean there, better access. There is a journal that was just taken over by the Interventional Orthobiologics Foundation. That's a nonprofit I started, more than a decade ago. With a donation from a billionaire, and that nonprofit continues. It does an annual conference. It's now taking over a journal, so that maybe that's what you mean. I'm not quite sure how to answer that question specifically. So having a regenerative medicine journal is something that's already in process there, and that'll be through IOF, which is a nonprofit I started. I've been involved for many years, other than I show up as the old man at the conferences and give some lectures, but IOF is now a going concern. It's now the world's largest orthobiologics foundation. They just rolled in one of the other large organizations, which is something you can do when you get started with funds by a billionaire. Amanda, can you explain what AAI is, and is there a certain type of imaging to diagnose it? Can a person have both AAI and CCI? Yeah, Amanda, CCI, if you remember those crazy Venn diagrams from high school, right? CCI is the circle, the big circle, and AAI is the little circle within the big circle of the Venn diagram. So basically, craniocervical instability is the larger term. Atlantoaxial instability, or AAI, is the more specific term for C1, C2. Now, CCI can occur at C0, C1, C1, C2, or C2, 3. Those are typed based on the typing system I created. So a type 1 is going to refer to a 0-1 instability. A type 2 is going to refer to a 1-2 instability, and a type 3 to a 2-3 instability. As far as AAI diagnosis, the most accurate AAI diagnosis out there is going to be through a digital motion X-ray, simply because that can handle types 2A and 2B the best. CT, rotational CT, not all that accurate, regrettably. I wish it were. Upright MRI, not going to really be able to diagnose that type of CCI well, although it can pick up on some of the bigger type 2As. But the more subtle type 2As are probably going to be missed by an upright MRI. Jessica, is there a ligament that can be blown in the front of your neck on the side, not in the spinal canal, or is it just muscle in the front? Not on the side. So ligaments in the front of the neck would include the anterior longitudinal ligament. That's kind of like a piece of duct tape running right down the middle. Out to the side, there are certainly lateral ligaments that go from transverse process to transverse process. Those are called the intertransverse ligaments. I don't know that we see lots of patients with injuries to those, but that's possible. But one of the things that you could be experiencing, if it feels like something deep in the front, could be problems in the longus coli muscle down in here, or longus capitis muscle up in there if it feels very deep, because those are very deep anterior cervical muscles. Eric, digital motion x-ray showing occiput skull lifts off the atlas. C1 on the right side and skull slides on atlas. Do you recommend upright dynamic MRI before sending info to you? Regular MRI not showing anything except one MRI CAT scan. Yeah, Eric, so to diagnose those kinds of CCI, DMX can be good in that you can see certain trends in the movement, right? Having said that, it's not going to be super accurate for giving us metrics. So for that kind of type 1 CCI, an upright MRI with flexion-extension or a CBCT with full flexion and full extension, again, both of those have to have full flexion-extension, tend to be better because we can measure various benchmarks, right? We can measure BAI, BDI, translational BAI, translational BDI. We can look at the morphology of the 0-1 joint. So those are the kinds of things that would be seen on an upright MRI versus a DMX. DMX is going to give you more qualitative information there, whereas an upright MRI will give you more quantitative information to say, yeah, that's normal or that's abnormal. Why not open to something in Europe? I'm not sure I said that. From our standpoint, why won't we do a PICL in Europe anytime soon? Have not had good experience with European providers on that topic. And I don't have any ability to tell a European provider, if I think they're not qualified, that they can't do a certain procedure. You know, these are very, 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 very difficult procedures to do. They take an immense amount of technical skill. They take an immense amount of very expensive equipment. For example, $300,000 worth of C-arms, $40,000 for endoscopy, $70,000 for a good ultrasound unit, 3D printed mouthpieces, which cost a lot of money to create. So in my experience, that's not available in Europe, or not in the same way it's available in the US. And B, I've not had good experience with European providers to date. The two that I know that we talked to about this were cowboys, right? They just decided to do whatever the heck it is they decided to do without much training, without really understanding what was going on, why it was going on, and how to keep patients safe. So not going to go to Europe anytime soon because of all those reasons. Where do you perform PICL? It's performed only in Colorado. Nathan, it's typically more difficult for transverse nalar to regenerate than the rest of the cervical spine. Not that we've seen, when it comes to ligament, I would say that the upper cervical spine tends to take more treatments, but a lot of that is because we get those patients much later. And in addition to that, they tend to have more neurologic involvement. So for example, in the upper cervical spine, we'll see vagus nerve involvement. We'll see occipital nerve involvement, greater occipital nerve, lesser occipital nerve, third occipital nerve. We'll see superficial cervical plexus involvement. And those are kind of things we generally don't see in the mid and lower cervical spine. So the mid and lower cervical spine would respond more quickly, but I think that has a lot to do with the fact that there are fewer things going on and fewer nerves and structures getting injured that can cause havoc in the patient. The upper cervical spine seems to be the body's sweet spot, that if you want to cause absolute havoc for a patient, try messing with the upper cervical spine and that'll get the job done. Caleb, awesome, thanks. That's what happened to me, great. Tom, you mentioned something about going into a grocery store and getting dizzy, panic outside of box. I noticed this is something that flares me up, or very other overstimulating environments. Why is that? I'm 7 weeks after my PICL treatment. Can I start vestibular therapy to address this in the meantime, or should I wait after my PICL to start the therapy? You know, Tom, why is that? Let's start with that. So the first thing is that when you're walking down a grocery store aisle, your eyes kind of dart from left to right as you look at the different products that are there. In fact, there's a whole science involved in getting you to look at those shelves, right? So as you do that, you also move your head and neck around, and because you've got an upper cervical problem, the visual system is not tuned into and not providing accurate information that fits with what's coming in from the upper neck. So that causes a mismatch, which causes the dizziness. From a treatment standpoint, after a PICL, can you start vestibular therapy? Probably not a great idea, because the problem isn't vestibular, right? The problem's coming from the upper neck. So I would reach out to your specific provider and maybe ask if it's a good time to start something like postural therapy, or if you're higher functioning, maybe starting some of the vision exercises that we have online. But vestibular therapy isn't going to help as much because it's not a vestibular problem. It's an upper neck problem. Casey, and how do you diagnose an intertransverse ligament injury? Intertransverse ligament injury is much harder to diagnose. They're much smaller ligaments that go from transverse process to transverse process here on the side. Now, you could see on lateral bending DMX some additional motion that happens at one specific level, but we don't really know what to make of that, meaning we don't have any standards to apply there to see what's normal and abnormal. So that's a hard one to diagnose. We're also not going to really see it even on top quality MRIs like 3 Tesla, just because those ligaments are so much smaller than ligaments like alar and transverse, for example. Okay, any more questions out there, guys? Again, this will be my last Facebook Live before I go on my sabbatical. Do me a favor, if you like having a doctor come here and answer your questions about this topic, then please give me a like, share, subscribe, all that great stuff, because that's how YouTube tees this up for other people that are interested in this topic. If we don't do that, then no one can find this information. And the more patients we have asking great questions, the more we can all learn from each other's problems, issues, diagnoses, imaging, etc. So please do that now if you can. Another question here, 2 questions. Krista, thanks for answering our question. CCI education is so important since not many providers understand it. Question, I have a lot of dizziness and imbalance if a surface I'm walking on is not level. Is that proprioception problem? Yeah, so Kristen, to answer your questions, first, yes, walking on an unlevel piece of ground is going to be more challenging, right? Because your body wants to write the visual field, and it wants to keep your visual field horizontal at all times. So if you're walking on an uneven piece of ground, your body is going to have to move your neck to right that visual field, which is going to put more pressure on one side of the upper cervical spine than the other, and that can cause more dizziness. As far as the level 1 exercises, yeah, if you can only get to about 8 reps, then I wouldn't push that. Other things to consider would be looking at that rehab program I have online, and also considering whether or not something like postural therapy with Todd Ball might be a good next thing to try. After 2 treatments, would you see an inner neck injury? Not sure what that means, Lindsay. After 2 treatments, would you see an inner neck injury if I'm symptomatic? So yeah, you'll have to ask that in a different direction because I'm not understanding what the question for me to answer is there. Greg, thanks again for your time. Have a good time off. Look forward to seeing you in late October. Be well. Well, thank you, Greg. Look forward to seeing you as well. Eric, thank you, but it takes anesthesia to find out the real laxity. I have muscle knots and SCMs and other areas that can never have trigger points injected ever again. Symptoms were dizzy, head too heavy, high blood pressure, high heart rate, and muscular lockdown. So let's examine that. Does it take anesthesia to look for laxity? No, but there are times where the answer is yes. So for the most part, for most patients, it doesn't, but it does take full range of motion. So if you're doing flexion extension x-rays or an upright MRI with flexion extension, you got to get to max flexion and max extension. Now, having said that, we have had patients, for example, in particular at the atlantodental interspace, that had normal flexion extension x-rays or normal DMX and flexion extension at the ADI. And then when we put them to sleep, that opened up. Now, that's pretty rare. I would say that's probably only a couple % of the patients we see, but it does happen for sure. We also have other patients who probably do have some instability, but they can't get enough range of motion without something like a Valium, for example. So that does happen on the edges, but is not super duper common in day-to-day patients. Casein is treating the intertransverse ligaments. You just injected the lateral tips transverse process. Yes, but realize that's also where the vertebral artery runs, and that vertebral artery supplies blood to your brain. So it's possible to inject them, but higher risk than other types of injections. So based on that, it's always a risk-benefit equation. Katie, thank you. I hope you have a wonderful break. Well, thank you, Katie. Hello? Liam, for people applying for the pro bono program, what is the actual poverty line for the U.S.? Thanks, Doc. Oh, Liam, let's see. I think, let's look that one up. I got a number in my head that I want to. Yeah, I was right. So for a single individual, it's $15,650. For a family of 4, it's $32,000. So just give you an idea. Hello, doctor. Can you tell me if CCI is more common in patients with Marfan syndrome? That's an interesting one. I would think the answer to that could be yes, because of some of the spinal hypermobility that can occur there. Having said that, do I have a lot of CCI patients who clearly have Marfan syndrome? I don't. So is that because there just aren't that many people with Marfan syndrome? Is that because it's not so common in Marfan syndrome? Is that because Marfan syndrome patients with CCI don't seem to find me? I'm not sure. Brent, since symptoms can be caused by different issues in the neck, how do you determine when to inject a facet and when not during a hands-on exam? Say a facet has no pain but has the associated symptom. Yeah, Brent, that's a really good question, because there are times when we have to use both, right? We have to use a hands-on exam of tearness in that joint, but we also need to pay attention to the associated symptoms that can come from that joint. And a really good example there is C2-3. So I will not infrequently see a patient that's not all that tender at C2-3, but has dizziness. Well, C2-3 is probably the number one level or a facet joint associated with dizziness based on the literature. So we'll add it in based on that. So yes, it is a combination of hands-on exam and also looking for the associated symptoms with that specific level. Amanda, would it be possible to get CCI or CCS from falling asleep in the car with neck and flexion and suddenly you wake yourself up and fling neck backwards into extension? You know, I think, Amanda, much of that would depend on the patient, right? So, for example, is the patient hypermobile? We see hypermobile patients getting CCI from relatively minor things. Maybe they had CCI before and whatever the minor injury was, it was enough to push them over the edge. Or is there a pre-existing problem that happened at a prior date where things are kind of hanging by a thread? So those are the kind of things that might cause that kind of trauma to be associated with CCI. But is the average person that does that going to get CCI? The answer is no. Lindsay, after 2 PICLs on my neck ligaments, are there any others you might not treat the first time, like interneck ligaments that were mentioned earlier? So Lindsay, I think what you're maybe referring to is if we have a patient who's a fragile egg patient, we're not sure how they're going to respond, we may do less is more on the first one, meaning a less is more approach, where we try to just focus in on the ligaments or structures that we think are going to reduce a possible flare-up, but give some bang for the buck, so to speak. Now, as we go forward in that kind of patient, we'll open it up as we determine that they can tolerate more. But realize at the end of the day, that's only in a subset of our patients. And the vast majority of patients, we're injecting everything we possibly can that first time, unless we're concerned about a potential flare-up. My head pops when I look up and to the side. Could this be an inner neck ligament after 2 PICLs? Could be, sure. When you look up, you're relying on lots of anterior ligaments. So the anterior extension of the ALL, for example, known as the SAAOL. You're also relying on the anterior AO joints at the front of the C0, C1 facet joints, for example. So those are the kind of things that maybe want to be looked at for additional injection. Now, the SAAOL is commonly injected, but the anterior AO joints not as much. So it is possible that those need to be dialed in further for a third procedure. Casey, assuming advancements in gene therapy, do you see hEDS getting a genetic fix? Yeah, probably. I think we're starting to just now see what I call the genetic treatment dam break open a little bit. Genetic treatments go back to the 90s with viral vectors, but there was a bad accident or something happened. I even forget the story now, in a patient in the 90s where they were trying to get FDA approval. The FDA really then slapped on the brakes on genetic treatments. And it seems like we're now starting to get some more. So between that and AI starting to do all of our medical research, which will probably happen around the early 2030s, meaning I don't think we're going to have many medical research scientists by the early 2030s. The few that we'll have left will be working with super intelligences on how to do this. I think you'll see sometime in the 2030s, the pace of medical advancements probably double, triple, quadruple over what they are today based on the use of AI superintelligence rather than human medical researchers. So that's good if you're an EDS patient for sure. Lindsay, can I ask the right way at my follow-up? Thank you. Have a great sabbatical. Yeah, so Lindsay, just bring up to your physician that we discussed what's called the anterior AO ligament as a possible target. So just write that down. Anterior, meaning the front part of AO ligament. Eric, I felt a max out feeling of don't go any further or something could really happen. Worst doctor gave Valium to stop whole body spasms and bladder issues, alcoholic, 2 beers or 3 with help. Head move even further. Yeah, so Eric, medications, alcohol, all of those things can relax muscles, and then you can get more range of motion. Now you have to be careful there, right? If you're getting more range of motion specifically for an imaging study, that's one thing. But if you get that extra range of motion and you pay for it the next day, that's an instability sign, and you don't want to do that. Brent, when a facet joint is palpated, can you feel how swollen it is? Is it being swollen in this context, a reason to inject? We can feel some swelling, but more what you tend to feel is hypertrophy. So what that means is, for example, you can usually feel in most patients ridging or bone spurs in the back of the 1-2 joint, for example. The 2-3 joint is another one where you can usually easily feel if the joint is bigger and arthritic. So the answer is we can feel more increased joint size, that what we call hypertrophy, due to arthritis in the joint. That one's really easy to feel for an experienced person. Now realize the thinner the patient, the easier that stuff is to feel. The heavier the patient, the harder it is to palpate that stuff. What would symptoms of torn anterior AO joints be? Yeah, we don't use the word torn because most of these things aren't torn as much as they are stretched out or have partial tears within them. So example, just as we were talking about, right? Many of those patients, when they look up, they have a certain set of symptoms, and that looking up is the nodding type motion that happens at the 0-1 joint. Okay, next question is a little weird, so I'm not going to ask it. Okay, guys, any other questions I can answer? Again, last shot here before I go on sabbatical. And I wanted to make sure that I answered some questions. I'll be answering questions while I'm on sabbatical a couple times a day on the PICL Reddit sub. So that's one that you should consider joining if you haven't joined that. Let's get to that here. So that's the PICL Reddit sub there. Let's experiment with how to make that a little better here, guys. I'm not quite sure. Anyway, that's the PICL Reddit sub. So you can join there, and I'll be answering questions there as well. And then I'll obviously start these back up once I get back in town. Let's see some more questions here. Yeah, got that one. Let's see here. Sharon, hi, Dr. Centeno. May I ask, does CCI ever get missed because the patient doesn't relax in the upright MRI? Can the numbers be far off? Yeah, so that's an important point, right? I do think, well, let's go back to what the research says, because there's a relatively old study, 20 years older or more, that says that there's a high false negative rate in flexion-extension x-rays for instability. So what does that mean? That means that about 2 in 10 to 3 in 10 times when someone does a flexion-extension x-ray and they're looking for too much motion or instability, they miss it because the person usually doesn't get far enough. So it could be due to spasm that's preventing that motion, but if you push the patient into full flexion and full extension, you're more likely to see that instability if it's present. If you don't push them, then you're more likely to miss it. So that's really what you should strive for in all of those movement-based images, as much motion as you can possibly get. Happy to help, Eric. In evaluating patients for regen treatments, when would you get blood labs to optimize outcomes and what diseases are needed? Casey, and we really don't do any blood labs like that to optimize outcomes. Obviously, if someone's a diabetic, those are things we would be concerned about because they're going to have poor healing. But that's usually something they'll come in with. Or if somebody is anemic, that's something we need to know. So we always check for anemia because that determines how much we can take. But I don't think there's huge differences in outcomes with regen procedures based on what we can find in your blood or not find in your blood outside of a few different parts and pieces. Thank you. Have a wonderful time on sabbatical. Thank you, Lindsay. Can PRP help range of motion in cervical facets? If that decreased range of motion is due to swelling in the joint or pain in the joint, the answer is yes. So that would be a pretty common improvement with well-done PRP facet injection. So what's a well-done PRP facet injection? Number one, use a high enough dose for the patient's age. So you got to go high dose if the person is middle-aged or older. Number two is you are using X-ray guidance with contrast confirmation to inject those facet joints. Gotcha, Amy. Chris, I had T5-6 bulging disc show up on my imaging many years ago and has been acting up again. Can you treat that? Yeah, so yeah, Chris, that's something we pretty commonly treat, meaning at the end of the day, our focus is to try to treat things that are clearly involved in that kinetic chain. So for example, I will frequently treat unstable SI joints when I'm doing a PICL or TMJs or thoracic disc bulges with radiculopathy. Those are all common things for me to treat. Having said that, if we start seeing stuff for me on my schedule, since my schedule is a bit different, I'm only doing PICL, that isn't related to clear kinetic chain issues, like someone's got a right ankle or a right wrist or an elbow they need me to treat, then I do start drawing the line if we don't have enough time to do it during that procedure. But if it's kinetic chain spine involved, I usually try to get that in because it's my experience that treating different parts of the spine, one affects the other, right? Because it's only a cervical spine because we called it that, but it's really the top part of the spine machine. The thoracic spine is the thoracic spine because we call it that, but it's really the middle part of the spine machine. And the lumbar spine and SI joints are those things because we call them those things. But that's really the lower part of the spine machine as it intersects with the legs. So because of that, I usually try to treat those at the same time. Anja, is there any particular DMX imaging centers in the US which you can recommend? Sure. I think Dr. Katz does a great job here in Colorado. I think the original DMX place in the Clearwater, Tampa, St. Pete area is quite good. That's DMX Works, WORKS. And then there's other standout providers here and there around the country. We have a DMX list. But if you're trying to get from Europe into the East Coast, which may be the most convenient thing to do, then you might consider that DMX Works in St. Pete because they're pretty close. Also, there's quite a few directs from Europe these days to Denver as well. So Dr. Katz's office is great as well. Casey, any room meds like DMARDs or other immunosuppressants that need to be held? Yeah, Casey, and so anything that is a strong or even weak anti-inflammatory needs to be stopped. So any of the biologic rheumatologic medications, those things ending in MAB, monoclonal antibodies, what that stands for, those need to be stopped because they're powerful anti-inflammatories that can block an acute healing response, and we don't want that at all. Amanda, my lumbar MRI said years ago that I had bilateral spondylolysis at L5S1, a pars defect. Another MRI done last year, and it doesn't mention any of this. It's something that can heal on its own. Could be. Also could be that it could still be there, and maybe it just was misread, or maybe it was initially misread. That's something I'd have to look at both MRIs to really get a sense of. But it's possible. We usually don't see those heal on their own, though. Brent, I consider you to be the leading expert CCI at CSC. With all the due respect, can we expect the same level of diagnostic care and treatment from other docs, or do they have their own methods? Yeah, Brent, I mean, that's, I think, a good question, right? One of the things I work hard at is trying to make sure that the other docs at CSC, for example, get all of the updates. So we are all able to inject the upper cervical spine, for example. That's part of our training. And to work at CSC, you have to go through our fellowship. There's no way around that. So we have doctors working at CSC that we've hand trained. Now, having said that, PICL is different. So when we bring a new CSC doctor on for PICL, there's a lot of additional training. That training now extends into how they evaluate patients, for example. And on top of that, there's a review of their images to make sure they're doing everything right. Or as the PICL advances, all of that flows into them as well. So I think I do a pretty good job of trying to make sure that everyone at CSC is trained up to my standard. Having said that, we're all individual doctors, and we're going to bring a little bit of ourselves to the table as well. And some of that's just personality and how we approach patients, etc. But the goal is to try to level that playing field as much as humanly possible. Regarding upright MRI, techs tend to place or rest the patient's forehead on a padding, thus with positive pressure backward. Yeah, I would agree, Robert. Not a good practice. You don't want that to be the case. Now, I understand why they do it, and it's one of the downsides of upright MRI. It's one of the reasons why we probably don't see quite as much instability in some patients as we should, and one of the advantages of DMX, because you have a fluid motion where you're stopping and then reversing yourself, whereas if you're going to lay your head on something in an upright MRI, that is going to reduce the likelihood of finding instability if it's present. So I agree with you. That is not a good practice. Hey guys, give us a like where you are, because that's how other patients find this. And we want other patients to find this. The way to pay it forward in the CCI community for other patients that are suffering is to make sure they can find content like this. Anja, in case lower neck is not moving, can one get it to move without chiro manipulation? So there's a couple of reasons why a lower neck might not move. The most common one would be a lot of osteoarthritis in the lower neck. That can happen pretty commonly, and that arthritis can lead to decreased motion because of bone spurs and arthritis in the facet joints, and also degenerative disc disease. Now, if it's due to something else and not big arthritic changes, then things like facet injections can improve range of motion there. Chiropractic adjustment can improve range of motion there. Working on the range of motion and physical therapy can also do it. Sharon, I've heard of a certain gel they inject into the hip joints to stimulate cartilage growth repair. Have you heard of this? It's something you do. I think you're probably talking about some of the things that are available more for equine here in the United States. There are some of those that are approved, like Penisan, in certain parts of Europe, but they're not approved here in the United States. In the United States, we have hyaluronic acid, which is sort of the standard knee gel stuff or lubricant. We don't have Penisan here that's available for injection, regrettably. Now, I've talked to vets that use it. To them, it's kind of the same as hyaluronic acid, meaning it's not magic, and it's not regrowing cartilage in their experience. Katie, before getting a PICL, do you prefer a more recent DMX? The original one was over 2 years ago. Probably not needed. If finances are an issue, then we'll probably just go off the old older DMX. Nathan, is there any possible explanation why a flare-up would make it painful to straighten arms and fingers? Sure, that could be a flare-up of the lower cervical nerves. Those would extend. Realize nerve is one cell from the spinal cord all the way down the arm in through the end of the fingers. So when you're extending your fingers, right, you're stretching the nerve. So if the nerve is pissed off up here, that's something that can happen. Also realize that nerves are structured like Chinese finger traps. They're structured so they can get shorter and longer because you have to do that to be able to move your arm out, for example. So at the end of the day, yes, probably pissed off nerves in the neck would be the number one leading possibility there. Anja, if no pain is present, can one expect for any long-term pain to emerge after the PICL procedure? If no pain is present. So I think you're saying you don't have any headache or neck pain. And can you get headaches or neck pain from a PICL procedure? Anything is possible. Is that a common result? No. Is it even a rare kind of common result? No. But anything is possible with any medical procedure. And at the end of the day, that's important to understand that any medical procedure can cause new symptoms that weren't there before. Now, good news is we're at about 2,500 PICL procedures. And so we've got a pretty good idea of what that risk matrix looks like. And it's dramatically safer, for example, than a surgery. But anything can cause anything in medicine, from medications to procedures, surgeries, etc. Aiden, what are your opinions on peptide therapy pre and post PICL to enhance healing? I don't think we have any hard data that peptides do squat for healing. So I understand they're used fairly widely. So I've looked, for example, at BPC 157. The results, if you actually had BPC 157 and you could come up with a delivery system to get it into your cells, which is a big if, I don't think what's being sold out there does that, then it looked kind of like PRP. So I wasn't quite clear on what was special about this. Nor do I think it's even likely that most people getting sold BPC 157 would even get it into their system. So not a big fan for any of those things right now, simply because they're not FDA approved medications. They're illegal to sell. I don't know if the FDA would get on a patient about buying it, but they're certainly illegal to sell. And we don't have much evidence that they do anything in humans at this point. Krissa, restarting the CGRP meds 3 to 4 weeks after PICL, is there a benefit to trying to hold out longer if one is able to? Yeah, if you can hold out longer, that's great, right? What we're trying to do there is to avoid any impact on acute inflammation of those medications. And at the end of the day, that's in the 3 to 4 week range. Having said that, what we don't know is there any change in the remodeling phase of healing? That we don't know. So I would say 3 to 4 weeks at the very least. If you can stay off longer, that might be helpful. But at least that 3 to 4 week mark is probably a good target. Brent, thank you, doctor. I really appreciate what you and your team are doing for us patients. Well, thank you, Brent, to try to get out here and work hard for patients every day, answering things on the Reddit sub, doing things like this, putting out all the content, trying to make sure that people get educated, because, again, an educated patient, in my experience, is a patient that tends to get better quicker. Sharon, now I remember what it was for cartilage repair, chondro filler, I believe using this in Germany. Yeah, so I don't know exactly what that one is. Let's look it up. Chondro filler. Okay, so it's a collagen. Basically looks very, very similar to the type of collagen injections used in the skin. Do I think it's going to magically repair cartilage? No. I think the evidence wouldn't show that even on the animal side. We don't have in the US a collagen approved for knee injections. Having said that, you could use the stuff for the face in knees. We don't do that because we don't really see it making a big difference based on the animal data, meaning the fact that you can get rid of an osteochondral defect in an animal is relatively easy to do with pretty much anything. Taking that then into a human and having it do the same thing is much, 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 much harder. Casey, I've heard of your lab growing menisci using autologous chondrocytes. To me, how could that be anchored to bone? We don't do that. So I'm not quite sure where that came from. You've heard of lab-grown menisci. Gotcha. I understand. Now, I don't think that is something that's commonly being done. Is it possible maybe you could find a place in the world that's doing that? But I would agree you're going to have a problem with anchoring it in the same way that allogeneic menisci from other people or donor menisci have the same problem, right? They don't anchor really well and they tend to get fractured and spit out the joint quite a bit. Aiden, would reverse lordosis impact the initial healing phase from a PICL procedure? It's something that can be targeted. Yeah, so Aiden, that's an important thing. I think you want to get on that curve restoration as soon as possible. Some CCI patients can't tolerate it, so we have to do that later. But if you can tolerate it, getting on curve restoration would be very helpful because it's going to take pressure off of those CCJ ligaments. Okay, guys, I think we're done here. I'm right at about an hour, so I've got to get packed, do all that good stuff, etc. So I want to thank you for, I think I've been at this now for 7 months straight, 7 months of fantastic questions. I'm going to take about 5-6 weeks off where I won't be doing Facebook Lives, but then I'll be back answering more questions for another 7 months. It was maybe 3 months. 7 months on the other side. And I want to thank you for all the great questions tonight. I will be continuing to answer questions on the Facebook sub. So if you join that the Reddit sub, RPICL, then I can answer questions there. I'll be answering those questions when I'm gone. Thanks so much for watching tonight. Have a great week. I will be answering questions on the Reddit sub, and I will see you guys in 5 or 6 weeks. Thank you.